Hello, everybody. This is Mark Lynn from Healthcare Business Specialist. I'd like to welcome you to the Advanced RHC Billing 401 session, sponsored by North American Healthcare Management Services, and it's going to be presented today by Charles James Jr. Here is my contact information. Here is Danny Gilbert's contact information. She'll be working with us on technical issues. If you have questions, please ask Danny. Here is what Healthcare Business Specialist does. Right now it's cost report time, so get your cost reports in because we are working on those as we speak. And so also the Facebook group, we have about 3,500 members. If you're not a member, please join the Facebook group. You'll get lots of great help from people like Charles James as well. If you do have questions, you can type those into the sidebar over here, and we will try to address those. I know Charles has a really full schedule here, so I don't know how much time we'll have for questions, but put those in there. And we are accumulating those questions, and we're trying to get answers pulled together for you guys as well. The disclaimer: everything is current as of today. Charles will only be talking about Medicare. Charles is really super smart, but I don't think even Charles can know what 50 different states, 50 different Medicaid programs are doing every single day. Although he's pretty smart, he might be able to. And then disclaimer, where you're going to be able to find the slide presentations, I did put them in the handouts over there. So if you want to click in your sidebar that says handouts, you can find them there. I put them on our website at ruralhealthclinic.com, RHC webinars. And that's where your recording will be. Once this is over with, I will put the recording on YouTube and you can have it there. We're winding down our lunch and learn sessions there. We're going to have a PRF reporting session on Thursday. And we'll talk about Medicare bad debts as well. So if you haven't done that, sign up for that. Danny Gilbert will be doing a session next week on TennCare. So if you're from Tennessee, this is only state that's going to interest you if you're in Tennessee, on TennCare quarterly reporting. And then Joe Lampard is going to be doing a session on the HPSA shortest designation. There's about 1,000 HPSAs that are subject to be withdrawn in the near future. And so Joe is going to update us on what's going to happen to those HPSAs, how it's going to affect your RHC, and that's coming up next week as well. So here's Charles's information here, and Charles, I am going to switch it over to you, and you can tell us a lot about North American Healthcare Management Services, what you guys do, and you should have control of the screen now.
Excellent. Well, thank you, Mark. You're always super generous in all these platforms just to get this knowledge out there, to share it. A bunch of consultants is really nice. So thank you as always. We probably ought to take just a heartbeat or two in solidarity with our humanity in Ukraine. They're dying right now. Let's just take a couple heartbeats in honor of the folks that are fighting for their lives right now. It seems silly to talk about what may feel trivial while that is happening, but our worlds go on. So I think you can see my screen right now. The big thing I want to talk about right now, everyone knows North America, not everyone knows, excuse me. I would like everyone to know that North American is an electronic health record vendor, as well as a revenue cycle management provider, so we're a billing service. Not only do we have our own system we work off of that we've tailored to rural health clinics, but we work off of all of the name brand systems. I'm not allowed to say those publicly or advertise their names publicly, but all those systems you work on, we work on, and we're happy to work off of other systems on all of our billing services. We do rural health clinic setup across the country. Our unicorn Cami Schneidler on the RHC compliance, our clinical quality officer, spreads magic and fairy dust wherever she goes for rural health clinics. So I'd love you to talk to her about your internal rural health clinic program. We right now are offering Rural Advantage. We're looking for participants. Rural Advantage is a Medicare shared savings, ACO. Our mission is provider and patient well-being. I'm going to keep this brief. ACOs have not returned value, and a lot of ACOs down to the providers at the bottom of the food chain providing the value. We've teamed with Pinnacle, an expert in the ACO field. They do for ACOs what we do for rural health clinics. They help us get set up, provide structure, compliance, management. These are the types of tools, I think we may have heard of some of these tools we use to provide quality care. When we at Rural Advantage come in, these are some of the areas we're helping with all the way down at the quantum level. That's our split, 75-25. That's different than everyone else out there. There's no cost to get in. There's no downside risk. It doesn't reconcile like rural health clinic. It's no cost to get in. Medicare shared savings is revenue on top of claims. Two totally separate things. ACO revenue, claim revenue. By signing up, you're out of your MIPS. You're out of your negative MIPS adjustment or having to participate with MIPS. We're enrolling participants. I'd love to talk to you about it. Provider and patient well-being. So we're signing up participants as we speak for performance year 2023. Now, as Mark mentioned, we've got a lot of territory to cover. And thank you, Mark, for, I hope I can live up to you saying that I was smart. So thank you for that. I think all of us here are smart people. And indeed, all those Medicaids make your brain numb. But we're here to talk about some pretty high level billing items. We're going to talk about a bunch of different claim scenarios, and all of that big list of questions, hopefully we address. I saw quite a few telehealth questions, and we're going to churn through some information here. So baseline, what goes on the claim form and how do we report it? Of course, not many of our claims go out looking like this. We're talking about ANSI 837 institutional claim forms, but the visual representation is here. And we're going to look at some remittance examples as well. Now, I said to Mark earlier that I think Amanda Dennison is probably going to be running the show one of these days because she's super smart and she did a great job covering a lot of the, I think she did 201, I'm not sure. She started digging into the nuts and bolts and laid a fantastic foundation that we know about our qualifying visits. And I don't want to go into any of these things in depth other than to lay a baseline for where a lot of this language and guidance is coming from and to make sure we know what we're talking about when we say modifier CG goes on our qualifying visit for revenue code 52X or a 900 behavioral health service, and that is going to represent the line item that Medicare takes co-insurance and deductible from. So the whole reason why those preventive visits and co-insurance and deductible, that we can't just do something simple like take the total charge. Because then if we did that and we report preventive services like we're going to see, the patient would be responsible for co-insurance off preventive visits. So we have to have this whole modifier CG thing to deal with. Amanda did a great job covering that topic. I'm just going to show a couple baseline claims to get us started. Amanda did talk about this direct supervision, and this applies to anyone under whom a claim is going out. So if it's a physician, we're talking about incident 2 services, nurse practitioner services, and incident 2 services. Sound familiar? Those are all of our rural health clinic services. Services and supplies. Incident 2 are limited to situations where there's direct physician or NP supervision of the person performing the service. Care management services, we get a general supervision threshold, which direct and general supervision become very technical descriptions. And I thought I had a slide in here that said, oh, well, it's right in front of me. Direct supervision is when the billing provider is in the clinic, not necessarily in the exam room, with the person providing the service. That's the language I thought that I had. So under incident 2, it's really important that direct supervision, we know that. And we're here to talk about technical claim detail. So let's talk about a claim where we do have some incident 2 services. This is where we leap off into difficult terrain right from the get-go. And Amanda, again, did a really nice job of covering this type of claim scenario where we may have multiple line items for one encounter. We see our 636 revenue code. We bundle our ancillary services up into the CG line item, and we may or may not have an extra $50 on our AR. Some systems, that extra $50 never even hits their AR. So a lot of this work for bundling these claims and how these claims get reported is probably handled by your practice management system. And we talked about this alternate or penny method, which is attractive, but creates other problems, particularly when we're trying to post remits and we have charges with a penny on them. It creates, it kind of unravels things down the road, where our alternate method is a lot of times much easier to automate. So incident 2 services, both of these are perfectly acceptable as long as we report detail lines greater than 0, and our CG modifier line contains our total charges to which coinsurance and deductible would apply. We're good to go. I put some scrubbed actual remit examples on here. So you see on this remit example, I'm not quite sure how our line items got out of order on this, but they did. So here's an example of a remit with exactly that type of service on it. You see we did 4 units of the medication, and that's what that will look like coming back. So our provider got paid the $80 over here, and this particular provider must have a fairly low rate. So we also talked about our situations where we have bundled services on different dates. For example, an allergy injection. Part of my guidance down here, don't span the dates, actually contradicts the claim processing manual. But if you span the dates on our claims, what you'll find is here we have 4 allergy injections. Let's say these were 1 per week. If we span the dates from 30 days before, Medicare thinks our patient has been in our clinic for 4 solid weeks. And for example, if that patient were to go to the hospital in the interim, the hospital claim would be rejected because the patient was in your clinic for 4 weeks. So that's why we typically report when we bundle multiple injections, even though in reality it's really difficult to do this. It's difficult to do this. I don't know how system-wise you automate this without having a smart receptionist and personnel that know, oh, hey, this person's getting allergy injections. Now I gotta put this allergy injection in. But regardless, we typically report the date of the encounter with the units of allergy injections. Here's what I'll say about allergy injections. I'm an MBA guy, I'm not a clinical guy. I can't tell our providers how often to see patients. What I will ask them is, how long is it reasonable to give allergy and give any kind of medication to a patient in your clinic without seeing them? Is a year reasonable? Probably not. Quarterly, monthly, I can't tell them because it sounds like I'm trying to manufacture visits. What I'm saying, if you don't have the encounter, there's no way to bill the allergy injection. So that's how to bill it. I don't have good examples of allergy injections, but it would just look exactly like that previous example we gave on the remit. During one of the previous sessions, somebody texted me and said, "Hey, Charles, tell us how to report nursing home visits." Here you go. It's really confusing when we talk about sniff. So a sniff would be a nursing home visit. Sometimes our providers don't know if it's a sniff bed or not. Sometimes it may be more convenient if you're seeing sniff patients in with hospital rounds. For example, maybe our rural health clinic providers still seeing patients in the hospital. We just keep all of their time carved out and bill the sniff as non-rural health. That's allowed to do. But of course, all of our nursing home visits, it's to our advantage to bill them as rural health clinic visits because as part of our mission as a rural health clinic. We also have a home visit in here. So nursing home, home, valid places of service for a rural health clinic encounter. Notice really the only thing on here is, of course, the CPT code, but the revenue code distinguishes that there's no place of service on those claims. Nurse-only visits don't meet the requirements for a medically necessary face-to-face encounter. It's the cost of including the cost of providing these is included in the cost report means there's no additional payment for them. That these are on the cost report phrase just means they're in to support your rate. And we're back to the incident 2 services provided on different days as a billable visit. You can roll those in if you have a good way to keep track of them. Boy, we're jumping now way over, hop skipping some territory here to get to global billing. Global billing in the rural health clinic is not the same as everywhere else. So surgical procedures that would normally have, say, a 10-day global billing period, when they're done in the rural health clinic, they don't. Today is the global billing period. If the patient that just had the procedure shows up tomorrow, and let's say there's a infection of the wound that we just took care of yesterday, and there's a medically necessary reason for my provider to see that patient and we document it, it's an encounter. Now, the trick is that services provided at other locations other than the RHC are subject to Medicare global billing requirements. So our surgeon that may see patients in our rural health clinic that does surgery at the hospital and does follow up at the rural health clinic, that surgical global billing period will follow the patient to the rural health clinic, and you would not be able to get an encounter for a globally billed surgery out of the hospital. Here's another good example. The OB at County Over delivers babies. The OB at County Over sends mamas back to our rural health clinic for follow-up for the delivered baby, which is wonderful. We love newly established, we love new mothers, right? But when we see a visit for that, so that visit is really in the global period for the delivery, and there's no way else for you to get paid for that. That delivery performed elsewhere where there is a global billing period follows us back to the rural health clinic. So that's the threshold. Nor on surgical procedures in the rural health clinic does modifier 25 do what it used to do for you in a non-rural health clinic. Before, in your non-rural health clinic, you would have put a modifier 25 on our office visit, and we're not going to do that anymore. As a matter of fact, ban modifier 25 from your rural health clinic billing because it means something different, and we're going to see that momentarily. But an office visit and a surgical procedure on the same day are one encounter. Of course, both of these are on our qualifying visit list, so if we just had a CG modifier on the joint injection, it would be paid by itself. In this situation, our patient is, somebody help me out here, 280, 10% is 28, so we're going to have 50. $8 as the patient coinsurance on this claim, I think, because we're in advance now. CG modifier gets the coinsurance and deductible, patient's going to get 20% of that absent deductible. Procedures by themselves, once again, no modifier 25. I'd say modifier 25 is significantly overused anyway, but we're not going to use it to report a separately identifiable line item with an office visit anymore. It just gets paid as one encounter in these scenarios. So down where we have the office visit and the wound repair, that patient's going to be responsible for what, $130 of this particular visit. So everyone always also, gets concerned that they lose out on procedures. Some you might, sometimes that's inherent to rural health clinic. There may be some line items that you lose out on being rural health clinic, but you really have to go, just because your charge for the wound repair was $550, what's Medicare going to pay on it? It may be $276, but you may be getting pretty close there with that coinsurance. So always crunch the numbers, and remember, don't, as providers say, I'm losing on my procedures, and they think they do way more than they are. But crunch the number based on allowable, not charge. Preventive services and same-day billing. I think we get a lot of questions about how to report preventive services and sick visits. So remember, we have two kinds of preventive services. We have those that are eligible for same-day bill, which means we get a separate encounter payment when they're performed on the same day as another. Get how that goes together? On the same day as another, we get two encounters. Well, guess what? There's only one that qualifies for that. Our welcome to Medicare visit is the only one that qualifies. And our welcome to Medicare visit is not required to get the CG modifier. You can put the CG modifier on it. You can leave it off. Remember, the majority of the reason for the visit scenario. And I couldn't find claiming or remit examples for everything we're talking about. I don't have a welcome to Medicare claim example. But this, of course, if we reversed these line items, and most often the patient does come in and say, hey, I'm here for my welcome to Medicare visit, but they're also really sick. And it's really up to the provider to determine, in that case, first, CMS. And one time I've been collared by CMS and gotten in trouble was when I started telling people to have preventive visit patients come back for the preventive visit. They said, no. You treat the whole patient while they're there. You don't have a policy that the patient has to come back. See, my date of service here is a little out of date. But then the providers really are ultimately going to be the ones to decide what is the majority of the care that day, the office visit or the wellness visit. This would be two encounters. The patient would only have a $20 copay. That should be pretty easy. $20 copay on the $100 99213. We get a second AIR on the welcome to Medicare. Everything else is a standalone encounter, which means it's furnished on the same day as another medical visit. This should say is not a separately payable visit, and co-insurance and deductible are waived for all of these other standalone encounters. I like to say, hey, have a big preventive service party, but advertise all of them, not just one of them, because people don't want to fill the parking lot on depression screening day or STD screening day. So have preventive visit. I think these are great mechanisms. They're really important mechanisms, almost the most important mechanism for our value-based care conversation. And we are able to bill these at the same time as a sick visit. I've already said the answer to this. Why would we bill on this visit? Let's think about it. So standalone visit, we have an annual wellness visit with a sick visit or clinical visit. And annual wellness is standalone. So when rendered with another encounter, we just get one encounter payment. Why would we even report this? Well, A, we're required to by our participation agreement. And B, we need the annual wellness visit to count towards our quality measures. And of course, our patient needs the annual wellness visit. So that's one way we could report the annual wellness visit and the clinical visit. Let's say the annual wellness visit was the majority reason for the care that day. We could flip those two. And remember, the venipuncture gets bundled with the office visit. That is not a non-rural health clinic service. So in reality, when I look some of these up, oh, I got a well woman exam first. We talked about a well woman exam. Remember, Medicare does not pay 993 codes. The 993, anything routine, there we go. Oh, they're right in front of me, 99381 through 387, where on a commercial, we might report that for a well woman exam. Medicare, we have all of our annual wellness visits to choose from. So annual wellness visit, subsequent annual wellness with breast and pelvic exam and pap smear. And of course, any of the three of these would be standalone encounters. Probably not often going to have the breast and pelvic exam and a pap individually, but by themselves, and as long as it's the biennial one, they would pay. And so, of course, once again, we want our Medicare requires us to report all services, and we want coordination of benefits to know that these services were performed. Look at our claim example. So on our claim example, the subsequent annual wellness visit, and I don't know how well, I don't like using the markers, whoops, on these because I can't ever get it off the screen in time to proceed. But you can see our subsequent annual wellness visit got the CG modifier, and our office visit did not result in any coinsurance. And on this, there was no coinsurance because the annual wellness visit was the majority reason for the care. So let's talk about multiple encounters. Multiple encounters are allowed when we have a subsequent illness or injury. Patient comes in the morning, leaves, hurts themselves in the afternoon, 2 visits. As we just saw, well, excuse me, that's third. Behavioral health and medical visit on the same day, 2 visits. Remember, we can have a 52X or a 900 revenue code, and we have welcome to Medicare and a sick visit on the same day. How about welcome to Medicare, behavioral health, and a sick visit? How about subsequent illness or injury, 2 visits, welcome to Medicare? I've never seen a claim like that, but it could theoretically happen. Now, we do have a lot of vacation where we have behavioral health and a sick visit on the same day. We obviously have a lot of annual wellness visits, sick visits. It's not a multiple encounter situation. Fewer welcome to Medicare and sick visits, but plenty of those too. I couldn't find claim examples of them all, but first let's talk about, and I couldn't actually find any claim examples of this. I don't know how many people probably use this because it's also, it doesn't happen a ton, first of all. I'm doing a big implementation with a system that is on Epic, and we have all these claim scenarios that we're trying to find claim examples for, and they just don't have any yet. And this is one of them. This is what I talked about, our 59 and 25, excuse me, the 25 modifier is no longer used like you used to. It's interchangeable now with a modifier 59 that in our rural health clinic means separate conditions or treated and unrelated. Modifier 25, I always get the language a little confused now, but it doesn't matter. The language means we have a separate encounter, and these 2 modifiers are interchangeable. From the FAQ, we have some kind of awkward language. Is the CG modifier reported on the subsequent visit? No. Should the CG and 25 or 59 be reported on the subsequent? No. Modifier 25 or 59 is reported only on the line that represents the subsequent visit. So let's take a look. Because of course be interchangeable. I don't know if you'd come in for a laceration repair and then have an awesome visit later in the day, but you could. Here we have an office visit, somebody came in or whatever, hurt themselves. We have a $250 laceration repair, and you know what? Those charge amounts should not be bundled like that. So disregard the charge amounts over there. I just noticed that. That part of the example is incorrect, but the CPT reporting would be. So we'd have 2 separate encounters and each would be paid. Now also, no, you wouldn't be able to just bill them on separate claim forms because the second one would bounce. But like I said, please ignore my charge bundling. That's not the appropriate way to report that. It should be reported as $100 99213 is a $250 laceration repair. Remember behavioral health and a sick visit on the same day? At Medicare, we only have 7 approved qualifying visits for behavioral health. And this would be the one time where, other than the optional case of a welcome to Medicare visit where we'd have 2 CG modifiers on the same day, we'd have 2 encounters for this. You know what ends up happening when we look for claim examples is that normally these end up being submitted. And I think a lot of systems, because it's 2 different providers, separate the claim forms. So it didn't have a claim, it didn't have a remit sample. It errored out. So this is often split into 2 separate claim forms, which is same difference. Oh man, I hurt my eyes. This hurts my eyes. This hurts my eyes. It's the negative payment. So the negative payment occurs when our deductible amount, our charge amount exceeds our rate and the whole thing went to deductible. So this this rate must have been in the 120-ish range, but yeah, that would make sense for I think where we took this. Of course, scrubbed all the detail out of it. This was a 99214. It does result in this negative payment over here, and there's no correct way to do this other than to say, we used to in the old days when this first started happening, people would call up and they'd call Medicare and say, hey, how am I supposed to post this? And Medicare said, I don't care how you post it. What are you even calling me about it for in the first place? Because we just send the remits out. You post the payments. The only thing we have to be sure of is the patient balance comes out correct. And they are taking money back from a future payment. Now, what I didn't include is at the bottom of your remit, you'll have the transactions that they're taking the $17 from. But they are taking money back. What they're saying is you're going to collect the full $130 from the patient, but we're not going to let you collect more than your rate in deductible amount. Cannot collect more than your rate in deductible amount, so they take the difference back. Hey, we have a big deal. We have a new RHC encounter definition. So we're going to jump topics to our new definition of a visit, and that is now, of course, there's some other language in here. In this Reg 4052463, it describes visits, so it gives our full medically necessary visit, face-to-face clinical visit. It refers to a mental health visit. Then in subsequent section, it defines what is a mental health visit. And now, as of January 1st, 2022, a mental health visit is a face-to-face encounter or an encounter furnished via telehealth. So now we have a regulatory redefined, regulatorily, that's not a good word. We have a redefined encounter to include behavioral health visit rendered via telehealth. It's a big deal. It includes audio only. So this change allows us to report and receive payment for behavioral health visits same way we currently do, and include audio only when the beneficiary is not capable of video technology. A lot of our folks don't have a computer or a smartphone at home. It's reality, even in 2022. We have to have an in-person visit furnished within 6 months prior to the tele. So they have to be an existing patient. We have to have seen them in person 6 months prior to. We have to have an in-person non-telehealth visit every 12 months after, and exceptions may be made. Document the exception in the patient's medical record. And you can see right here, when you get these slides, this is a really important resource. The Rural Health Clinic Center website provided by CMS is where they release a lot of new information. We're going to use a revenue code 900 with a CG modifier. Whoops, and I just skipped the guidance. Modifier 25, or modifier 25, got that on my head. 95 for asynchronous video, audio video, and FQ for audio only. Those are our two claim types. 95 for regular old telehealth. It's amazing we have regular old telehealth now. It's kind of a new thing. Is that oxymoron? Anyway, FQ telephone only. G2025 still exists. It still exists. Do we know what the payment comes from for G2025? Do we know what that is? The RHC, FQHC distance site provider payment during the PH only is right now $97.24. It went down from $99.45 in 2021. And this is an aggregate payment, so it represents the average of the national physician fees, the national average of the, holy cow, man, it's difficult to say, I'm just kidding. It's the national average of all of the Medicare services that are approved on the physician fee schedule for telehealth services. There are 249 of them now, I think. Basically all the office visits, nursing home visits, and everywhere else visits, you can do evaluation and management via telehealth. So it's a whole, it's non-encounter. So if you have a bunch of G2025s, make sure those are taken out of your cost report because those are non-encounters. And I'll tell you, making sure those come out of your cost report is saving people's rates. So those are non-encounters. That's why we have a G2025. Patient coinsurance, we got an extra period in there. Patient coinsurance will be based on the lesser of the charge or $97.24 for this billing year. So there is a coinsurance. People were getting some elevated fees on this when we first got the code, but Medicare changed on SE 20016. That's our Medlearn Matters for Telehealth. Medicare changed the coinsurance application to the lesser of $97.24 or the charge amount. So if you charge 90 bucks, you get 90 bucks. Charge 100 bucks, you get 80% of $97.24. The patient's going to have a coinsurance of 20% of that amount. Telephone only counts. Remember, G2025 is only during the PHE. So telephone only can be reported as an encounter during the PHE, but what's going to happen after the PHE? We don't know. We have to have 5 minutes to qualify as telephone only. We see on this slide right here where 441, 442, and 443 are included in G2025. Those are Medicare telephone only visits. What I would anticipate after the PHE, telephone only services will revert to virtual care services, G0071. And I think what will end up happening is, I'm skipping ahead of myself. We'll get there in a second. So telephone only visits are included in G2025. We can do annual wellness visits during the public health emergency and telephone only annual wellness visits using audio only technology. That's what that means. We can't get a video connection. The patient can self-report elements of their status, height, weight, blood. I believe they've come up with other guidance to report that later, but you can do annual wellness telephone only for right now. Of course, anything in G2025, it was originally everything we were doing was COVID related. So anything COVID related, coinsurance waived. Now, CS modifier, anything COVID related, was certainly applied to non-telehealth line items. You're assessing somebody for COVID. CS modifier also applies to preventive services rendered via telehealth where we're waiving cost sharing. So CS modifier is for COVID related services to waive coinsurance and for preventive services via telehealth to waive coinsurance. Because, as I mentioned, coinsurance does apply to the G2025. That's what slide I was getting after. G2025, my crystal ball, this is Charles James only, my crystal ball says that G2025 will be extended for a couple of years after the end of the public health emergency. And we'll keep that code until we decide whether or not we're going to get all rural health clinic encounters eligible via telehealth. I bet is we don't, because I don't think people want to open that Pandora's box. I think we'll, for the foreseeable future, we'll have this G2025. That's just me talking, but I think that's some of the conversation that's happening with the policy. Who I just said, it's a big rule that I try not to say. A lot of the policymakers are, they don't want just somebody sitting in downtown St. Louis like I am, pumping telehealth encounters from a rural health clinic all day, every day. That's what is hoping to be avoided. So, CS modifier, we already hit that. There's that MLN 20016. It was just, actually that date is bad. It was just revised again on January 22, I think. It's definitely January 22. I'm not sure what particular day in January, but that is your go-to for all telehealth material. My standard references in here, Mark, we got through all of that material really quickly. So that was a lot, but this is an advanced course, so you can handle it. And here is a good, it's a rural provider and supplier. So you got to get down to the rural health clinic section. But all of the topics that we've covered in this series are covered in summary in that reference guide there. So, Mark, my objective was to save some time and get through a few of those questions.
Yeah, you've done a good job. You did it right on time. It's 1:43 Eastern time, and you saved me a little bit of time here. I am going to go over something real quick. I'm going to take up about 2 minutes of our time, if you don't mind. And
of course,
I think now I am back being the presenter. Let me see here. Where? Okay, Ken.
Great.
Am I presenting now yet? Let's see. Slideshow from beginning. Oh, hoping that was the wrong. Okay, so now everybody can see my stuff here. People really are confused by negative reimbursement. So I wanted to go through the numbers real quick with you just to see why we have negative reimbursement, because it's hard to understand. So maybe if you understand the why, then that will help you. So here's my example. To make the math easy, the first visit is a $233 charge. That is the Medicare deductible for 2022. Our rate, our all-inclusive rate, is $113 for this period of time, and our Medicare payment is going to be zero from Medicare. And so this is an example when they actually don't take negative reimbursement. They just don't pay you. This is not the way it is, but this is the way you want it to be, where they don't do anything. So this is a zero here. So the other payments we have, and this is through the full year. So this Medicare patient saw us 4 times. Our other 3 visits, we got paid our rate, which $113 times 80% is $90. So we collected $270 during the year from Medicare. We also collected $233 deductible from the patient or their secondary insurance, and another $90 in copay. So that is what, $300 and something we collected from them, $323. So here's a summary of what happened. Our charges were $683. We collected $323 from the patient. Medicare paid us $270. We had a Medicare contractual, which we cannot collect. We're going to have to write that off. But that turned out what looked to be pretty good for us. Unfortunately, when we went to the cost report, here's how our cost report works. We have a cost cap of $113 a visit. We had 4 visits during the year. Medicare says your allowable cost was $452, but wait, we have a deductible of $233. So we're going to subtract that from that and make your reimbursable cost $219. And then they say, but wait, you have a copay of 20%. So we're going to subtract another $44 from that. And that's going to drop your reimbursable cost down to $175. And guess what? You receive $270 from Medicare. So we want you to pay back, when you get your cost report settlement at the end of the year, we want you to pay back $95. And that would basically be per Medicare patient would have the same issue because everybody has a deductible, everybody has copays. So in theory, if you had, say, 500 Medicare patients, you'd be looking at a $47,500 payback on your cost report. And you'd be yelling at Mark at this point because of this. So what happens is Medicare says that's going to be a bad result. So what we're going to do is we're going to cause the pain up front. And we're actually going to take the money from you in January and February of each year. So when you submit the same claim we talked about before, the only difference is we have negative reimbursement of $120. So in this case, we have a $233 charge that we're going to collect from the patient or their secondary insurance. We're going to send the claim into Medicare, and instead of sending us $0 or $90, they're going to say you actually owe us $120. And we go through our year. Now our net collection is $150 from Medicare because of that withhold. So let's see what happens to our numbers now. Our charges are $683. Our patient is still paid us $323. Now Medicare has only paid us $150. This makes us feel a lot worse about having Medicare. We thought about, wow, Medicare is a really good deal. This made me realize how little actually Medicare pays. So they paid $150 for this. We now have a $210 contractual, but when we run our numbers through the cost report, same numbers that we did before, now our Medicare payment is $150 and our reimbursable cost is $175. So we actually are owed a little bit of money here. And I think this is because of the copays that on this, the $120 that they withheld from you, there was a portion that was probably related to a copay on that. That's why there's a little bit of a variance here. So the numbers aren't going to work out exact, but that gives you an idea of why Medicare does what they do. And so we get a lot of questions about posting negative reimbursement. And here's your charge. I came in on January the 1st. You charged me $233. I owe you $233. And when you submit that claim to Medicare, they don't send you any money. They actually take money away from you. So that's going to be a $120 contractual adjustment. Don't put that against the patient receivable account because they still owe you $233. Don't try to make them pay you that additional $120 that Medicare took from you. That's not, the patient had nothing to do with it. That's what Medicare did. And so if Medicare just says we're going to withhold $120 from you on the next claim, there was no money to supply it, then you're going to put in Medicare payable. It's going to be a liability because the next claim that comes in, you're not going to get that money. Or if they actually withheld that cash from you at that time, then you're basically just going to credit your bank account for that $120 because you didn't get that $120 that you thought you were going to get. And at that point, you'd have to actually lower your patient. And that's you would lower your cash in your bank account. Okay, let's go to our next claim just to show you how claims should be posted. Your charges are $150 on your second claim, and when your patient receivable is $150 from that. So that's going to be a debit. Your charge is going to be a credit. That's a sale, so that's good. When Medicare pays you that $90, you're going to debit your bank account, and you're going to credit your accounts receivable for $120, and then you're going to have a Medicare contractual of $30 as well. So those are some of the numbers here. Let's see, the billing incident to services. This is another example. we have the 36415. We add that to our 150, our 99213. That means our charge is 170. When our bill goes to Medicare, remember we have to bundle this 20 into our 150, and that gives us $190 as the total charges. That's not what's in our accounts receivable system. And when the remittance advice comes back to us, our copay is going to be $34. It's going to be 20% of this 170. So we're going to have a copay that's owed from the patient of $34. Our cash is going to be $90. Remember, it's going to pay you 80% of 113. And then they're going to tell you that the contractual adjustment is $66. And unfortunately, in your system, it's really only going to be $46 here. You can see this is a big difference. When you post the claim, that $20 difference, they're not going to match up. So your system has to have the ability to handle that. And systems like Charles has, and some of the other systems that are out there, they understand this and they can handle it. They handle that a lot better than if we'd have changed this to 1 penny. So when you post your charges, your patient accounts receivable is going to have a debit of 170 and a charge of 170. Your contractual adjustment, whenever the remittance comes in, you're going to have a contractual adjustment of only $46, and your cash is going to increase by 90, and your accounts receivable is going to drop by $136. Remember, your patient is still going to owe you $34 at this point here. It's going to be the patient receivable. It's going to be $34, which is the patient copay. Your charges are still going to be 170. Your cash collections will be 90, and your contractual adjustment will be 46. So that's just a sample of going through what should be happening in your system there. Danny, do you have some questions for Charles so he can answer those questions?
Yeah, let me look, because I think you answered some as we were going through, so I'll skip on those. Bear with me. Okay, here's one. When billing preventative visits, Medicare wants an E&M visit charge even when no other problems were discussed. Any ideas on what we might be doing wrong?
So say the first part again, please.
Mm-hmm. When billing preventive visits, Medicare wants an E&M visit charge even when no other problems were discussed. Any ideas what we might be doing wrong?
Yeah, I think we're mixing apples and oranges. So in a preventive, I guess I'm confused how where Medicare is requiring the problem to be reported for the preventive visit. You know, we're going to have, of course, in our notes, problem you discover and treat or address during the annual wellness visit, but you're generally going to have that annual wellness code on there, plus some other diagnoses. So I'm a little confused by the question, I have to say.
Yeah, I'd say the MAC is really not correct in asking them to put an E&M code on a preventive service. If you've got a G0438, you've done a preventive service. There's no requirement to have that. So something's going on your MAC there.
Yeah, I would ask for a supervisor.
Yeah.
Okay. The next one is, sorry, my little girl hit her toy in the back. If you can hear it playing. Can an RHC bill for a psychiatric mental health nurse practitioner?
You know, yes. And I'm giving a behavioral health presentation in San Antonio at National Association here in just about 10 days. A little more than that. Here's the problem. Absolutely, it's an advanced practice nurse practitioner. Psychiatric counts. That's a specialty nurse practitioner. But if that psychiatric nurse practitioner, let's say, is the nurse practitioner for that clinic, you have a solely behavioral health rural health clinic. So while advanced psychiatric APRNs and nurse practitioners count for rural health clinic encounters, they can't be the only provider there because we'll violate the 51% primary care rule. So that goes in whatever ratio you've got. If you've got multiple providers and you have one advanced APRN, psychiatric nurse practitioner, you're probably fine, but you still have to maintain that 50% rule.
Hey, Charles, this is Mark. This is a question that I've been seeing a lot, and I'm not real sure about what the answer was. That's why I didn't answer it before. But it says here she's billing a Medicare annual wellness exam virtually in the RHC, and she's been advised that since it's telehealth, she has to bill it under a G2025. But she's saying that the MAC is denying it, saying that the diagnosis code, the Z code, is not valid. So again, is that a MAC issue? Because to me, that's the way you'd want to bill it. So,
and you have to put a CS modifier on it.
Mm-hmm.
So, but if that's denying with a CS modifier and the MAC's saying that, yeah, you're going to have to go back to the MAC. Yes.
Yeah, and that's a good point. When you're billing preventive services, just like you would bill when you're billing for COVID services, you're gonna put a CS on there. When you're doing a G2025, make sure to put the CS modifier if it's a preventive service, because there are no deductibles and copays. That's a great point. Okay. Other questions, Danny?
Mm-hmm. Emily asked, what about the non-QVL list, or was that talked about on another webinar that I missed? You'll have to forgive me. I don't know when that question came through on your presentation, Charles.
Well, there really is no non-QVL list. And, there's this theory that the qualifying visit list is suggested and that other codes that might be relevant may apply, but I've never been able to get anything not on the QVL to pay. And I think that the QVL is on the, I always mix the acronym, the OCCE edits.
Mm-hmm.
I think that QVL resides there, which then kind of hard codes, anything not on the qualifying visit list, hard codes a bounce if those are in the OCCE edits. So at the beginning of the qualifying visit list, it says something about this is like suggestion or something, but in reality, it's pretty hard list. Firm. It's on it or they're not.
Danny, I think that's pretty much all the questions that I can see on there. Is that pretty much what you see?
There's a few others if we have time. If not, I'm sure we can answer them.
Yeah, I think what we'll do is it's right at our time to be over with. So why don't we close it down for now? Now, what has happened is we've had 4 different sessions, and your questions, we've been accumulating those. We've been getting answers together. What I want to do is have just a Q&A session after the National Association of Rural Health Clinics meeting, mainly because my schedule is booked until then, and I'm getting to go this time. I'm so excited. I get to see Charles in person for once. Yeah. So that's going to be great. So I'm going to go and I'm going to work on answering those questions while I'm listening to Charles, but there may be a speaker that I don't really listen to that I'll work on that during the session. So when we come back after the conference, and if you haven't had a chance to sign up for the conference, I know there's some space available. So because I just signed up yesterday, so go ahead, sign up for the conference. We'll see you there. Thank you guys for doing this. Thank you, Charles, for giving us a great presentation and being such a great supporter of this Lunch and Learn webinars. I think they've been really, really helpful, and we've had a lot of people be a part of this. So we thank you guys for joining us for those. They're not over yet. We still have a few more. So sign up for those, and y'all have a great day. Charles, Danny, thank y'all very much. We will see y'all next time.